So now we are moving to identification and stratification of chronic kidney disease in primary care, and I'm going to present you a patient journey. So I would like to present David. He is a male of 47 years old. He is a diabetic patient for almost 5 years with dyslipidemia, hypertension, and a newly diagnosed diabetic retinopathy. His blood pressure in examination is 135/85. His body mass index is 26. His A1C is 7.8. His estimated GFR is 90, and his urinary albumin-creatinine ratio is 60. In repeated examination tests, he had almost the same results of eGFR 90 and UASR of 60. His total cholesterol is 255. His triglyceride is 350. His LDL cholesterol is 115 milligrams per deciliter, and his HDL cholesterol is 42 milligrams per deciliter. His current treatment is metformin twice a day, Ramipril 5 milligrams once a day, and atorvastatin 20 milligrams once a day. So the questions that we are asking now: which stage of chronic kidney disease should David be diagnosed with according to his results, his laboratory results? Is it stage 1? Is it stage 2? Is it stage 3A? Or is it stage 3B? Please vote. Yes, so this is the table that you can put David in. So just to remind you, his eGFR is 90 and his UASR is 60 milligrams per grams. So according to KDIGO classifications, David is in stage 2. Is eGFR 90 and UASR 60, so he's actually in the yellow square of this table, meaning stage 2, and that means moderately increased risk in CKD. So now we are going to talk about identification and diagnosis of CKD in primary care, and I will move to Professor Mehmet Ungan, who will present it, and the stage is yours.
Thank you, Baruch. I think we have to start with the risk factors that should trigger screening for the chronic kidney diseases. Yeah, those are the risk factors which we face during the primary care consultations, and mainly hypertension and diabetes are the most frequent risk factors which we face, and when we see them we start to think about it. And of course cardiovascular diseases and the family history are the main clinical risk factors. And we have to also just think about, we have to consider that if there is a systemic disease affecting the kidney, like systemic lupus erythematosus or obesity or some genetic risk factors, environmental exposures to nephrotoxins, demographic, older age, race, ethnicity, those are all factors that we should consider, and especially history of the acute kidney injury. And if we think about them, what tests should be ordered is the question usually, and whether we are applying those, whether we are remembering them or not. I think it's always good to have them on our desk, that we have to order the creatinine and eGFR and urine ACR values, and those are the main tests that we should be considering when we see the risk factors. The creatinine and eGFR ratio measures the kidney function, and if the eGFR is lower than 60, we have to repeat in 3 months or sooner if there is a clinical concern also. And looking at the urine ACR, and it measures the kidney damage, injury, protein excreted in urine. And if urine ACR is equal or higher than 3, we have to repeat 1 or 2 times more over the next 3 months. One test is not enough to make the diagnosis of CKD. And a persistent abnormality for at least 3 months is the key for the primary care physician. I think there is another important point that the CKD detection should be carried out in absence of an acute intercurrent illness. Otherwise, low eGFR in such scenarios may reflect acute kidney injury and require more rapid evolutions. And I have to mention not to go for overdiagnosis and just considering some kind of primary care physicians who are not having enough infrastructure like ultrasound. So I think routine use of the ultrasound is not required unless ruling out a cause of acute kidney injury. So how to interpret those results when we get the test results? For me, to be honest, it's not easy to go, when we get the results of these 2 tests, it's not easy to go and to look at in a crowded patient load in a primary care center to check one by one all the tables. But we have to know that there is a KDIGO chronic kidney disease follow-up guideline. So we should be really looking at that in order to refer and in order to be timely acting about the chronic kidney diseases.
So now I would like to open a discussion between our faculty members and to ask them, after we have recognized the importance of identification and stratification of CKD, to understand a little bit what could be the barriers for the GPs to do it correctly and periodically, and what are the solutions that we can offer to do it simply and in a more correct way. So Mehmet, I would like to ask you, as you have finished this nice presentation of you, what do you think could be the barriers of the GPs and how we can overcome them?
Yeah, that is a very good question, because as I told you during the presentation, it is not easy for a primary care or GP or primary care physician, especially if they are overloaded, to use a guideline or kind of a table and to go and to put those results to there. Although one by one, if you consider to use it in that way, you can do that. But if you are a busy one, it's not easy. So most probably the workload is one of the major problems that in use of those guidelines, follow-up guidelines. And also, I can tell you that there are some regions even in Europe that underdeveloped places, rural places, which the people are really working single. And it's really hard for them to one by one check those things. And there is a fear of making wrong diagnosis, or maybe fear of making an overdiagnosis and putting the patient into difficult conditions.
And what is your suggested solution for that?
Yeah, this is, classical GPs are not very happy, sometimes like me, to use the digital solutions in the daily practice. But then when we start to use it, automatized systems, let's say, like supporting the decision-making, they really help.
Okay, thank you, Mehmet. And I see that Sami is agreeing with you. And so please, what is your opinion?
Thank you, Baruch. I was just going to say that, I agree with the suggestion of automation, because GPs are very hard pressed for time, and knowing all these guidelines can be a bit daunting especially given the fact that they may not just be dealing with patients with chronic kidney disease. They will have patients with all sorts of other long-term conditions. You kindly listed all the risk factors, diabetes, hypertension, cardiovascular disease, and family history as being some of those common conditions. So in electronic medical records, for example, if computer systems can be programmed to identify these risk factors so that the pop-ups will be suggested to the clinician when they open the records for these patients to consider screening that patient for chronic kidney disease if the patient has all those risk factors but has not been diagnosed yet. So that sort of automation will help GPs a lot. The other thing that I probably just want to say quickly while I have the floor is you also talked about the diagnosis. We do know from the evidence that knowledge of the diagnostic criteria and the staging makes a difference a lot when it comes to giving appropriate management options. And you suggested eGFR lower than 60 and urinary ACR, urinary ACR more than 3. Now, those are very good markers to remember, but you did suggest repeating them 3 months later and not to just use the acute, numbers, which I agree with. The only thing I would say to that, in addition to my primary care colleagues, is that, especially with the proteinuria, when you have done the urine ACR and you see that the patient's leaking protein, that is a call for action. Yes, we're not saying you should rush to diagnose chronic kidney disease with just one test, but just that one test is a sign that there is something wrong in the system. In the cardiovascular system, it tells you that the basement membrane is damaged and proteins are leaking out. So that can be an early sign of cardiovascular disease. Don't ignore that. In the kidneys, podocyte degeneration is already happening. That's when you start seeing proteinuria. And so when you see that, even if it's a first up, don't ignore that. Please kindly repeat that 3 months later. And if it is still damaged, then you can confidently make your diagnosis. But don't ignore a one-off testing. Repeat it at least 3 months later.
Yeah, I agree. And thank you, Sam. And I think also one of our advantages as GPs that we see often our patients. So in case we are losing it in the first visit, we can see it again in the next visit of the patient. This is a benefit for us. So now I'm going to our specialist nephrologist, Louise. What do you think, Louise?
Yes, thanks for this. And I agree with the earlier participants' comments. I think the biggest barrier has been the measurement of the ACR, because we do blood work perhaps, more commonly. But I do think, as was just mentioned, that the ACR is often not, even when we're aware that they're diabetic or hypertensive and they're being screened, but unfortunately not including the ACR. So I think, how do we put that in our minds? I think kidney, so urine, there's an association there. So hopefully we can start to just, I know AI is important, but also that we start to think of that with it. And again, I think when you're talking to patients, because many times they're having to, urinate in a cup, that you have to tell them that it's like, you're examining, as we heard, a breach in the kidney, or as I say, that the car is leaking oil. So, that we're looking to see that there's some damage. And as we've already heard, the ACR, or having this protein leak, is an early indicator of kidney damage, kidney disease, and often occurs before any change in creatinine. So as we just heard, it is an indicator, I would suggest, of vascular disease when we see that small amounts of proteinuria without change in creatinine. And again, as we heard, an increased risk of vascular disease, whether we say cardiovascular, cerebrovascular, and now good evidence to even support that that's a signal for peripheral vascular disease may be also in the works. So again, I think the three, as we were saying, the diabetes and hypertension, that likely encompasses more than 50%. So if we can get those two categories out, vascular disease, your patients that are coming with cardiovascular disease, peripheral vascular disease, screen those. and the family history, I think that would capture, likely close to 75%. And then the AI or other techniques that you have, just gaining practice over time, understanding those other causes. But I think get those big ones in your bucket, first of all. Get your own system of doing both creatinine and ACR, again, that repeat. And then, you'll gain as lower the creatinine, the higher the ACR, the increasing in risk. Thanks, Baruch.
Thank you very much. So if we are going back to our case presentation of high risk, so he's need a close follow-up and treatment already.
Yes, he's right in that yellow category to treat. So really that is, make sure that blood pressures are under good control. If they're diabetic control, lifestyle, of course. We have good evidence of, monitoring lower salt diet, regular movement, as I say to patients. And again, looking for other risk factors, recurrent dehydration if they're working out in fields or hot work environments, or use of anti-inflammatory agents to look to see if there's any other causes that could be contributing. So gets to be, kind of that you've got them in that yellow zone. Definitely family doctors need to look at that and treat that appropriately. Thanks.
Thank you very much, our faculty members.